Welcome to the Cleveland Combined Hand Fellowship Lecture Series, sponsored by the Cleveland Clinic and Metro Health.
Good morning, everybody. This is another one of our combined lecture series. Today's topic is irreparable rotator cuff tears. And hopefully we can cover some bases here. And we have some questions at the end that hopefully we can run through the topics enough to be able to answer the questions intelligently. So my objectives here, just first off, to establish a common descriptive language, sort of to be on the same page with where the literature is. And then we'll go through surgical considerations and decision making, and then we'll talk about management. So rotator cuff repairs are very common. The number of surgically repaired lesions in the United States, this is, I think, from a 2012 review, was estimated to be in excess of 250,000 a year. It's a very common surgery. And then the failure rates are 20 to 94% structural failure, but this could be 0 to 90% depending on which study you look at. And then healing is noted to be associated with an improved patient-reported outcome, improved range of motion, improved strength, but some meta-analyses have not shown any clinically important difference between groups when you're looking at structural healing. Things like mental health, occupation, education level, hand dominance all play a role in whether or not these are affected and whether or not you should address this surgically or sort of move on. So the reason you repair, I just have this slide up to talk about the function of the rotator cuff, which is it medializes the head and allows the center to be a fulcrum, and the deltoid can act as a lever. So the structure and motion, healthy rotator cuff is a fulcrum on the head, and then how do you define a tear? So the size, the location, the pattern, the age of the patient, age of the tear, if it's symptomatic, or if they've compensated for the deficiency, all things to think about. So when you starting at the beginning of that list, we think about size. You can have partial thickness and full thickness tears. Partial thickness tears, we talk about articular sided, dorsal sided tears. Full tears, we measure in the anterior to posterior dimension, typically measured in meters. Medial to lateral dimension is also measured in meters, but there's pretty inconsistent reporting, and it's not always defined for every single study. And this could be tearing, or this traction. This could be a diagonal pattern. So this can throw you off a little bit if you're not really paying attention to how the study is built. But for sure, the P dimension is considered. Tendon involvement, they consider the size of the tear, how many are involved, which one. So looking at tendon involvement by looking at the rotator cuff muscles. The subscapularis is a little weak, has a slightly different function, it being the inferior cuff, and it's an internally rotator of the humerus. So you think about subscapularis tears as being upper border, or 50%, which is like the upper half, or complete retraction of the subscapularis. Supraspinatus, infraspinatus, and teres minor as a continuum. And then pattern, looking at Burkhart described, he tried to describe this in a manner consistent with the repair tactic, looking at different types. A crescent type, I'll have a small tear, anterior to posterior, and it's a crescent type, and then it's repaired simply. There's U-shaped tears, which are repaired in a complex way, where you have a repair of the longitudinal aspect and you convert it to a crescent type, then you repair a crescent type. So this is what we talk about when we say pattern convert. These are literally the images that should come to mind. There's L-shaped tears, where you have longitudinal aspect. Here, the typical L-shaped tear has a longitudinal component being a rotator interval, and then the width of the tear is footprint of the supraspinatus. You can release that interval and then repair that longitudinal aspect. Sometimes the corner here belongs here, should be recognized actually be back in the far corner. It may be here. So you just have to recognize that this is a U-shaped or a L-shaped. And then massive retractable tears is sort of another term that he came up with to describe slides where you have an anterior relief, posterior relief, and you independently stabilize the supraspinatus to allow sort of anatomic restoration footprints. Another complex pattern. Again, compared to like an L, where you have these tears performed as a consideration for pattern. Looking at the table concept, this is another thing to think of in terms of how large the tear is, the footprint is. He described in 1994 this idea that the suspension of the rotator cuff can medialize the head, and that if it remains in suspension pattern here, it can remain functional. So you try and off this a balanced shoulder, or you can have a functional rotator cuff even though you have a large tear. It's another thing that we think about when we look at large tears. Tendon involvement here to the footprint. In 2002, this did a study with using wires to look at footprint, measured the distance of each tendon. Study where they were able to describe the footprint sizes for each of the four tendons. You can see here A is the subscapularis, B is the supraspinatus, C is the infra, and D is the teres minor. Just in terms of size, you can see how the shape and the pattern of tears can definitely be defined in terms of their width. Width of the tendon footprint is the A to P measure tear. Another way to look at tears is which tendon is involved and not just simply measuring. So that's another classification system here that we get from Colin. He looked at type A, type B, type C, type D, type E, massive tears, which are two tendon tears. And he put the subscapularis into two portions, and then the supra, infra, teres minor. So you can see all these different types of large to massive tears, so that he could study them essentially. He proposed this method of classification in his work, which I think is very useful. Another way that we discuss these tears, and we use these words small, medium, large, and massive, and they have numbers that go with them. So for small, it's less than a centimeter, medium size considered 1 to 3 centimeter, large 3 to 5, and then massive tears are anything greater than 5 centimeters. We get this from Dr. Cofield's longitudinal study on rotator cuff tears. And then another way to look at massive tears is two tendon tears. Anything that has two complete involved in the tear can be considered a massive rotator cuff tear. And that was also propagated in the study by Zimstein in 2008. And it's been before that. It's an older definition, but this really took it off. And now we have 5 centimeters and 2 tendons being pretty widely accepted definitions for massive tear. I get back to the rotator cuff shoulder and looking at our function. If we have normal function and this balance concept, if we're thinking about, does this patient have a tear and does it affect their function? So if they are balanced, the idea here is that the head can be medialized by the rotator cuff. But if they have abnormal function, we start to look at what's missing and why they have the function that they do. So the term that's been defined is this combined loss of elevation and external rotation, clear concept. The thing to think about is they tolerate passive range of motion. Typically, they good. If there's no arthropathy, you should really think about more of a strength and function for this patient, and they maintain active. Oftentimes, if you can place their shoulder into their passive elevation, if they can maintain that, they can show you that they have strength. They just can't initiate that elevation. And then thinking about, do any of these qualify as pseudoparalysis? So trying to define pseudoparalysis with shoulder surgeons is an interesting way to get people to talk, because everybody has a slightly different definition. Here, Dr. Burks and Dr. Tajan suggested pseudoparalysis should only include elevation limited to 45 degrees. In some cases, there are patients who have, or studies who have patients that can elevate up to 90. And there's definitely a movement of in the literature of trying to get away from defining pseudoparalysis in terms of someone who actually has 90 degrees of forward elevation, so saying that's something different. And so just understanding what you're reading, I think, is important. For me, if I'm looking at something that deals with pseudoparalysis or large or massive tears, then I'm really going to be looking at what's their definition for pseudoparalysis, because if the patient can already get to 100 or 110 degrees, it's probably not pseudoparalysis. So just things to think about with being precise. Colin, when we looked at this tear classification earlier, so Colin looked at 100 tears that were all Goutellier stage 3 or higher. And for them, pseudoparalysis was only defined as 90 degrees. And he looked at tear patterns specifically, whether or not they had pseudoparalysis. So really, the B type and your C type were very common. Type D did not necessarily have a lot of pseudoparalysis. So this would be the balanced shoulder kind of concept. And then the active range of anterior elevation, looking at which types actually are limited in forward elevation. So he classified all this for each of these types. And he also looked at active range of external rotation with the side. So this would be your sort of the defined lag test or testing the strength of the infraspinatus. Here, this would be teres minor, where you've got the elbow up at the side at 90 degrees. Or the hornblower sign is what you'd be looking for to see if they can maintain that active external rotation. And so, not surprisingly, type E, which involves the teres minor, has the lowest range of motion here. So he just sort of justified these physical exam findings and correlated them to weakness in the rotator cuff muscles. And then, which he also interestingly looked here at internal rotation. So with the hand on the back, measuring which lumbar or thoracic level they can reach. And you can see there's definitely some correlation there with being able to reach really high levels. So anyway, this is just a common language. People definitely talk about type A, type B, type C. In the literature, they definitely talk about some of these deficiencies. So I think this is, for me, this is one of the first things I look at and think about when I'm looking at massive tears. So considerations and decision making, lots of ways to talk about it, but I think starting at the very beginning, non-operative management, physical therapy, cortisone, activity modifications, should all be the starting point for rotator cuff tears, whether or not this is a repairable tear or not. Operative management is where things get really interesting to decide if this tear, chronic or otherwise, is something that can be repaired. If you just want to go the route of debridement and decompression, there's always considerations for how to handle the biceps. For repairable tears, which I think should be the first consideration, tear mobilization, and whether or not you're going to include an augment in the repair, a partial repair, or if you're going to deem this irreparable, which is kind of what we're talking about. Something that I always look at is this review in 2017 by Brolin. He reviewed the Hamada classification and kind of went into detail with it. And I think for me, it's a good starting point for understanding their baseline radiology and not forgetting that arthropathy can definitely be part of the picture where you're looking at massive or irreparable rotator cuff tears. So for irreparable tears, this is something that you should not really be caught with. You should have a plan for how to treat this. So you don't want to decide, oh, maybe this is irreparable during surgery. You want to have that decision plan made before surgery. So anything that you can sufficiently mobilize and release but cannot be repaired to the anatomic footprint, like I said, ideally you're doing this, making some of these decisions before you go to the operating room. And then the literature supports potential for benefit might decline for anyone over the age of 55. Chronic tears, which would be 3 months. Some people are looking at pseudoparalysis as a reason not to address these tears or to come up with alternatives. And what are the options? So if you can't repair the tendon and it absolutely does not mobilize, you're looking at space fillers or tendon transfers and arthroplasty. Those are the big three options for space fillers. Superior capsular reconstruction has been definitely popularized for filling that space, acting as the bumper and trying to lower the humeral head height. The balloon, which is new, should be, I think, around this year. I'm not sure exactly when, but in the U.S., this is a saline insufflated biodegradable spacer. It's placed in the subacromial space. It's typically done arthroscopically. There's definitely a lot of studies looking at the efficacy of the balloon. Tendon transfers, Latissimus tendon transfer can be used, and the lower trapezius tendon can be used as well to replace the function of some of the rotator cuff tendons. And then, of course, for arthroplasty, rotator cuff deficient arthroplasty is addressed with the reverse design. In superior capsular reconstruction, Dr. Mahata in 2013 started popularizing this with fascia from the fascia iliaca in the leg. And this is an autograft. It's harvested at the time of surgery. And instead of an interposition style graft where you're connecting this graft to the tendon, he's actually anchoring it to the glenoid. And he reported improved outcomes for this method. You can see here he has 83% structural healing at 2 years. And in the U.S., this takes the shape of an allograft that's a dermal matrix allograft. And so the literature is a little bit different, but it's essentially the same procedure where this graft that's anchored to the glenoid instead of to the native stump of tendon. So he has 5-year follow-up for this. And using fascia lata, he studied 30 shoulders, and he evaluated who got tears and who healed their graft. And for those who had the graft healed, the tear size was slightly smaller. The acromial-humeral interval was slightly larger. These are all preoperative factors here that I have listed. The ACEs score was lower, and the pain score was higher, and they had lower range of motion. So maybe they had, I guess the way I interpret this is maybe the patients who healed were asking less of their shoulders and didn't have necessarily as much of a demand. But it's hard to tell that in retrospective. This is only 30 patients. Looking at the biomechanical strength of different ways to anchor these grafts to the glenoid, they looked at, this study looked at 3 different techniques. Essentially, the knotless technique was the strongest for anchoring to the glenoid with tape, silver locks and tapes, but they all had similar elongation of the graft. And this is with the acellular dermal graft. It's the difference from the fascia graft. Admin in 2020 evaluated 10 of his SCRs with the dermal graft, and he compared the sensitivity of ultrasound versus MRI for failures, recommending that if you're doing structural healing, you shouldn't really be relying on ultrasound because he only detected one, and it was a humeral-sided failure. I could detect failures at the glenoid side. So for 10 patients, he had 7 failures, and I think that's something to think about. And so these are some factors that differ between the intact and the failed, although with 10 patients, I'm not sure you could really assign patients to one or the other groups. Most of them probably fit in the average thing. And then looking at the balloon, in terms of, so, we're still looking at spacers, things that space. The subaqueous balloon here, they did a study on how much volume actually should go into the balloon, and they found that 25 mils saline best correct the proximal latitude of the humerus, as well as the test upper range of motion. It had results. And basically, the 10 was not enough, 40 was too much. Before they started to dislocate inferior throughout abduction. So they found the volume should be used. And looking at partial repair with or without a subacromial balloon, retrospective matched cohort study, both interventions showed improvements, but there was no difference between the groups. So it doesn't look like the spacer changes a partial repair. Another small study looking at patients who also had a spacer and what's the difference between debridement and anatomic repair. Here we see no significant differences. So the thought is that with spacer, debridement just as well as repair or a partial repair. This tendon transfers, now addressing function and not necessarily filling. Latissimus tendon transfers are classic transfers for posterior superior tears. Gerber looked at massive irreparable tears, looked at 14 transfers, and he had a minimum follow-up of 3 months. And 4 patients had follow-up greater than a year. These are photos of one of the patients before and after. So I think it's useful to understand you can get a benefit from latissimus tendon transfers, although it's somewhat less common as a transfer, but it's definitely an option for your superior tears. This is the surgery. So there's a posterior approach to the shoulder, and the transfer is docked either arthroscopic assisted or onto the posterior superior humeral head. So here we see they have some data that supported the latissimus for having an active role and not just a passive desis effect. Because I think some of these patients, you can actually ask them to fire muscle as they run through the range of motion, and you can see a shift in their external rotation. So I definitely think it does have an active role. It has both active and passive for a lot of patients, which is important. A new sort of gaining traction surgery here is the lower trapezius, the latissimus tendon transfer for anterior tears. So thinking about the subscapularis as a posterior-based structure behind the chest wall, so is the latissimus, and using this which is functionally an internal rotator of the humerus and an adductor, taking that in phase in line of pull and using the latissimus to replace the function of the subscapularis for irreparable subscap tears. So he looked at 50 cases, 14 were open and 42 were scope assisted, and showed very good results with the latissimus for the anterior tears. And he describes the different techniques and different docking in terms of the geography of where you're going to tendon depending on where your tear is. So you can see in the right here, if you have an anterior superior tear that involves the supraspinatus, you may consider docking the tendon higher to replace some of that superior pull, and lower if you're dealing with a subscapularis defect. So an interesting option for irreparable anterior subscap tears. Lower trapezius tendon transfer. This is something that's also gaining traction for posterior rotator cuff deficiencies. You can see here the pull compared for this is Latissimus. It's about 90 degrees to the rotator cuff, so at the line of pull. And then here you look at the lower trapezius tendon and then compare it to the infraspinatus. It's the same line of pull. So thinking whether you're in phase and you're in the same line of pull is another way to think about these posterior-based options. They looked at the biochemical comparison. These two essentially are making the argument with a line of pull here. So that the humeral resting rotation due to muscle load. See here it's a cadaveric study, so they have a normal shoulder they studied, torn superior posterior cuff, 12 newtons on the trapezius in the repaired fashion, and then they did the same thing for Latissimus. So they studied this, and the trapezius transfer, you can see here, essentially returned forces across the humeral head back near zero and in all ranges of motion than the Latissimus. So another fascinating thing to think about with the line of pull and how much it can actually change. They did the same thing for rotation here. You can see the compressive forces from intact at neutral rotation. You see the trapezius tendon transfer essentially returned almost the compressive forces. So another interesting way to study this. They did inferior shift. The best correction was seen with trapezius transfer, but again, studying this in a cadaver, I'm not sure how all of these make direct translation, but I think it's really good to understand the differences between Latissimus and lower trapezius transfers. Looking at these outcomes, there's definitely arthroscopic data now, but for the open outcomes, this is the original paper on describing this technique, and obviously improvements in forward flexion and abduction, as well as external rotation, and the dash you can see improves significantly here by just from 52 to 18, and they had 47 months of follow-up, so much better follow-up nowadays. Used to see with some of these transfer papers, like I said, the Gerber paper, definitely not a knock against Dr. Gerber, but is really not to evaluate a tendon transfer these days. And then looking at arthroscopic outcome, he described an arthroscopic technique where the incision is no longer vertical, but all along the line of the tendon, and then arthroscopic portals are made to dock the reconstruction on the humerus. And so if you're looking at the arthroscopic outcomes, they're pretty similar. Maybe they get they started off a little bit and got a little bit better forward flexion, but the abduction rotation outcomes were similar, and the data score as well had similar improvements. So making the argument that you're not missing out by converting this to an arthroscopic assisted procedure. And then looking at reverse arthroplasties, this for the young patient, this is definitely controversial. By young, I mean anyone under the age of 55. That's going to be controversial in the absence of arthritis. You can look at prognosticators for healing of tendon repairs in general, like smoking, diabetes, prior failures, and age. Surgical procedures can influence your decision to choose first, and a painful chronic massive tear, someone with some ability and escape may not benefit from other surgeries. The reverse may be the ideal option for that patient, and so I think putting all of this together is definitely important because this is sort of the end of the line for some patients, not for all patients, but a reverse is the end of the line for them. And so it can be very limiting in terms of what they want to get back to activity-wise. So you have to be understanding that. So looking at forward and then abduction, you use similar improvements. If you remember the trapezius transfer, the previous slide, you do an improvement in forward flexion, abduction, external rotation. Their pain scores and their ASES scores also show fast improvements. So we'll talk questions now. So this is a 40-year-old young skater presents worsening left shoulder pain and weakness. He injured the shoulder 3 years ago and for non-operative management. He's done physical therapy up until about 6 months ago, and now he definitely has functional limitations, including forward elevation to 120. He has pain. He has abduction to 100 and rotation to neutral. At 8 and external rotation at neutral with 5 degrees. He's got a positive external rotation lag sign, a hornblower sign, belly press and lift off normal, and a radiograph here is shown, or not radiograph, but a I is shown here in B and C, and so we're looking for the best treatment option. You can see on the coronal T2 sequence here that we have some absent rotator cuff tissue. There may be some scarring. Without scrolling, I couldn't see if it was scarring or a stump, but you definitely have absence of normal rotator cuff tissue here on the superior aspect. And then on the sagittal T1 here, you can see the muscle bellies have complete atrophy. We would call this grade 4 Tallier fatty degeneration. So the question is, what's the best treatment option? Therapy within his dorsal transfer, arthroscopic rotator cuff repair, pectoralis major transfer, or reverse shoulder arthroplasty. And this is Latissimus transfer. Of the options presented, that's definitely the best option, especially given that he's young and he has a chronic care. Another question here. 52 man has a shoulder dislocation, and at follow-up, he no longer has pain, but he has difficulty in his arm overhead. He has very good active or passive range of motion. He's got a positive apprehension test, and he's got limited strength with the anti-can test and external rotation to the side, compared with the opposite side, which is normal. The next step in management here is to get an MRI. The concern is obviously a rotator cuff tear. In this patient population, you may have instability, but the lesion may or may not be associated with a labral tear. It can definitely be associated with a rotator tear. And then which patient here has the best indication for Latissimus dorsi transfer? So you're looking for someone who's young with a irreparable posterior superior tear. So it's not number 2. So here the answer is the 50-year-old with the irreparable cuff tear. And then here, just to go back to clinical decision making, I didn't really say this much, but I definitely think repair should be considered first, and you should learn and the function of your cuff in rotator cuff patients, and understand what their goals are, and then understand what each option, surgical options, provide, because there's so many. There's several that we didn't even talk about, and it's definitely kind of a big web, but it's very highly individualized, and I think should probably stay that way for a little while, just because there's so many different ways to treat it. Thanks.
Well, that was great. So we don't often dig into irreparable tears or one topic. That was really good to expand on that. There are big problems still. Obviously, some new things on the horizon. Not many of us have done internet trap transfers. I know, but he's tried a couple of them. I don't know how they've turned out for him. Jonathan, you got any feedback on that?
Yeah, I think the big downside to the lower trapezius transfer is the bracing. There's 8 of bracing, and you have to be pretty strict with them. So I think that's the biggest barrier. But we've had pretty good results with these larger mills. We had a guy with a grade 3, grade 4 entire superior post cuff that did really well, and he can operate his machinery, so he can run, he can run his equipment. So it's definitely for guys like that, where they need to be lifting 50, 60 pounds with the shoulder, but they definitely need to use external rotation strength. It's something to think about for sure. I think it's also becoming an option for like missed greater veracity fractures. That's sort of another way that the lower trapezius transfer is becoming an option. So,
Yeah.
So yeah, I think the downside is definitely the bracing.
Yeah. How about the teres?
So
you described you showed a teres transfer, the teres major transfer. Did you not?
Oh, the latissimus transfer. Is that what you're talking about?
Well,
I had a latissimus for inferior subscleratus.
That's when I was phased out for a second, and all of a sudden this one actually is very interesting too. I'm interested in this a lot because I've given up on subscap reconstructions because they just don't work. They really are horrible. The line of pull is all wrong. I thankfully have not had nerve injuries, but I know people who have doing the pec transfers. So I decided to stop doing them after I saw crappy results and didn't want to wait until I got a nerve injury.
Yeah.
So this is very interesting. This is not technically very hard at all.
It's sitting right in front of you.
Yeah, this is an easy transfer. The question is, does it work? And I'd be interested to see that. I mean, really, and I see the different footprints you're showing there, and that's interesting. So one of the things that's a tip off on these big cuff tears, I think I've explained to everybody when you guys come to clinic, is when you see someone without OA, one of the tip offs is a plain film with a very large cartilage space. And you see large cartilage space, you see a well-centered head, and you go, something ain't right. They got supernormal cartilage. No, they lack that compression on the glenohumeral joint. And that's a pretty good tip off that they got a big cuff tear or an incompetent cuff of some sort. So, and that's what happens to these pec ones too. They either drift out the front or they tap. They look a little fun on plain fill. So there's this one, and then go to along. I think you showed that again. I was maybe, you were showing that the lower trap. Keep moving along there. Yeah,
this is the biomechanical study.
Yeah. No, it wasn't that, but keep moving. This must have just been the lower trap I was talking about.
Yeah.
Keep moving. Yeah. I was looking at one of the pictures you had.
This is a scope study.
Oh yeah. And what was this one now?
This is just how he sort of updated. He used to do these lower trapezius transfers, and he would dock them onto the humeral by making an acromial osteotomy. And so that's a devastating recovery. So I agreed. I think that's probably why it didn't take much traction several years ago. But now the reconstruction on the humeral head is just done typically like you would an arthroscopic repair.
Yeah, because these are either done with a 2-incision technique, a medial incision or lateral incision in the open way, or this arthroscopic assisted. So, this has promise to me. Again, not highly technical, I guess, after you get over your first one or two, but.
Yeah, it's the same. It's a similar time commitment as like a superior capsular reconstruction, but it has much more promise in terms of function. So, yeah, I think you kind of have to sort out how to do it because it's not a simple reconstruction. But yeah, after the first few, I think it's definitely feasible. But the patients have to understand the bracing is for 8 weeks. I mean, all of his failures are for people who gave up at 6 weeks.
Yeah.
So really 8 weeks is a sort of a match frame.
Yeah, there are some braces out there that are a little bit more comfortable than others, and I've tried different ones when I was doing my lat transfers, my open lat transfers. But they really do have to be rigid, in that almost minimum neutral to externally rotated position and slightly abducted, and it does help. And that's as awkward as hell living your life that way. But
yeah.
All right, very good. So excellent. Anybody have any cases for today? We're already at 7:29. You guys probably have the OR. How's everything going in the ORs? You guys getting a feeling of picking up?
Yeah, it seems to be getting closer to normal.
Yeah, I mean, there's definitely cases, definitely busy for me.
I'm hoping the bump in numbers don't cause any problems with elective cases, but we'll see.
Yeah. Well, good. And we'll thank you guys for a wonderful year of these presentations. Fantastic. Great job.